So good evening, everybody. Today is the second day of our ICOG reproductive medicine course, which we've just begun on Monday. Monday, we had two excellent lectures, which were delivered by Dr. Madhuri Patil and Dr. Asha Bakshi. Today, again, we have two lectures, which are going to be centered around male infertility and semen analysis, sperm function tests. So we have two eminent speakers today. One of the lectures is going to be taken by Dr. Madhuri Patil, who will be speaking later on. But first up, we have Dr. Sanjay Makwana. Sir is an eminent ERT clinician and endoscopic surgeon from the city of Jodhpur. And I think he's one of the pioneers in the field of endoscopic surgery. Started endosurgery in India way back in the 1990s. His center, Vasundhara Fertility, is recognized all over the country as one of the main centers for learning both endosurgery, infertility, high-risk pregnancy, all of the above. He has served on various different organizations, including IIG, ISPAT, and his wife, Dr. Renu Makwana, has also served as the president of ISPAT once upon a time. So, sir is here with us, requesting sir to please go ahead and share his screen.
Thank you, Dr. Pratik. I'll be talking about the etiology of the male infertility. Let me share my slide.
Good evening.
Good evening, Dr. Seema. So I'll be talking about the male infertility, basically the etiology of the male factor infertility. And as we all are very well aware, let me have the moment of the slide first. Yes.
You can just click on the slides.
Yes. So we all are aware about the infertility definition and the contribution of the male factor. We understand that there is a alteration in the sperm concentration, motility of the morphology. At least in one sample should be there out of the two. As far as the WHO is concerned, the male infertility is defined as the inability of a male to make a fertile female pregnant for a minimum of at least 1 year of regular unprotected intercourse. The male is solely responsible for about 20% of the cases and is contributing factor in the almost another 30 to 40% of the all infertile cases. In 50% of the involuntary childless couples, a male infertility associated factor is found together with the abnormal semen parameters. So before embarking on the etiology, one must understand the spermatogenesis, the basics. We all know that spermatogenesis takes place within the seminiferous tubules. The immature germ cells, they undergo the division, differentiation, and meiosis to give rise to spermatids. And spermatids are basically released from the Sertoli cell into the epididymis. During the passage through the epididymis, the spermatid, they undergo the biochemical changes, remain there in the epididymis, and from there they are released into the vas. The regulation of spermatogenesis is governed by the two major gonadotropins, that is the LH and FSH. LH target the Leydig cells to stimulate the secretion of testosterone, which acts on the androgen receptor in the seminiferous tubules, while the FSH target receptors are within the Sertoli cell to regulate the spermatogenesis. Initiation and the maintenance of quantitatively normal spermatogenesis rely on the balance of the hypothalamus pituitary testis axis. With this knowledge, we must understand what is the abnormal semen. Though the pregnancies can be achieved without any evaluation other than the simple semen examination, but as such, the test alone is insufficient to adequately evaluate the male patient. Analyze 2 or more semen samples obtained by the masturbation with at least having the 48 hours of abstinence to determine the density, motility, and the morphology using the WHO criteria. This is the WHO criteria, which was published in 2010. This is the 5th edition of the WHO manual. As per that, you can see the variety of the parameters given that include the semen volume, the total number of the sperms. There should be at least 39 million per ejaculate with the sperm concentration of at least 15 million per ml. With the motility, with the rapid linear and the non-progressive, both should be at least close to the 40%. Vitality must be more than 58%, with the morphology should have at least 4% of the normal forms. This manual also gives the nomenclature about the various terms used for the pathological semen quality, and that includes the aspermia when there is no ejaculate is seen, Asthenozoospermia when less than 32% of the progressively motile spermatozoa. Absolute asthenozoospermia is when there is no sperm moves at all, but they are still viable and not dead. Agiospermia, we all know there is no spermatozoa in the ejaculate. Cryptozoospermia is when spermatozoa is absent from the fresh preparation, but one has to go through the centrifugal centrifuge pellet to confirm, and if there is a present, then it can be labeled as cryptozoospermia. Leukoospermia is presence of the white blood cells more than 1 million per ml, then can be called as the pyospermia or the leukocytospermia. Necrozoospermia or necrospermia is a complete when all sperms are dead on the fresh semen sample, and incomplete when there is a 5 to 45% are still viable. In case of oligozoospermia, the sperm concentration must be less than 15 million per ml, where the total sperm numbers are less than 39 million per ml. Severe oligozoospermia is less than 5 million per ml sperms. Oligoasthenoteratozoospermia is the disturbance of all three parameters, that is the motility, counts, and morphology. And teratozoospermia is when less than 4% morphologically normal spermatozoa present. So this is a nomenclature given by the WHO in 2010, and accordingly we can categorize or see what we are looking for as to evaluate the fertility of a male. Let's come to the etiology. Etiology of a male factor infertility can be the acquired or congenital, other than the congenital or environmental factors. Acquired causes are mainly the bilateral obstruction or ligation of the vas, or maybe there is the cases of when the orchidectomy has been done for the positistries. There is an infection to the epididymis, maybe the transrectal resection of the prostate, varicocele or retrograde ejaculation. Congenital urogenital abnormalities may also lead to the male factor infertility. Maybe there is absence of the vas or dysfunctional obstructed epididymis, congenital abnormality of the vas, undescended testes, or ejaculatory duct obstructions. Endocrinological disorders include a variety of the disorders, and majority of them can be either there is a congenital deficiency of the gonadotropin releasing hormone, mainly in the Kalman syndrome, where there is a hypogonadotropic hypogonadism, or there is a head trauma, intracranial radiation, testosterone supplementation, hyperthyroidism, all can lead to the endocrinological disorders. Environmental toxins and the variety, they can also lead to the male factor infertility that include the insecticides, fungicides, pesticides, smoking, excess alcohol, or other chemical exposures. Genetic factors also contributing a good number of the cases that include the mutation of the cystic fibrosis CFTR gene, maybe primary ciliary dyskinesia, Kalman syndrome, Klinefelter syndrome, Sertoli-cell only, or Y-chromosome microdeletion. Apart from this, the idiopathic causes are also contributing almost 31% of the cases where the semen parameters are all normal, but still the male remain infertile. Variety of the immunological causes, malignancies, medication or drug abuse, then sexual dysfunctions that includes the premature ejaculation, anejaculation, infrequent sexual intercourse, or erectile dysfunctions. Then comes the urogenital tract infection, maybe because of the gonococci, chlamydial, syphilis, tuberculosis, or recurrent urogenital infection leading to prostatitis or prostrovesiculitis. All they can contribute to the male factor infertility etiology. Let's have the tabular distribution of them. The idiopathic, as I said, is contributing almost to 31%. Other factors like the infection is almost in the 8% of the cases. Disturbance of the semen deposition of the sexual factors can lead to up to 5.9% of the cases of the male factor infertility. Varicocele is one of the important cause, again found in 15.6% of the cases. Immunological factor also has 4.5%. Other abnormalities are close to 5.5%. History and examination as such is always important in establishing the etiology of the male factor infertility or any cause. History must include a detailed history where even the timing of the pubertal development, shaving frequency, hair loss, all should be noted down. Sexual history that must include the frequency and timing of the intercourse of the sexual practices. One must inquire about the eschatal trauma, childhood surgeries, genitourinary infections, STDIs, or even especially the hernioplasty or the vasectomy, which many times the people doesn't give. The history must be taken care in detailed history examinations. Examination is again very important. Most of the time, being a gynecologist, especially the female gynecologist, may miss the examination, but I'll stress here one should not miss it because it's very important to see the basic urogenital system of a male. If we are looking for a male factor infertility, gynecomastia, endocrinopathies are the important simple tests must be looked for. Other is the examination of the testicular size by use of the Prader's orchidometer. One can see by palpating the epididymis that the epididymis are turgid or the full. Immediately one can guess about the pathology in the vas or the obstructive pathology of the seminal vesicle. Same, the per rectal examination for the prostate and seminal vesicle pathology can be done. Otherwise, we can miss them because the examination of the prostate will give the presence or absence of the infection semen parameters. What is the goal? The goal is to identify the small percentage of the cases, which is as high as 20%, that can be normalized with the treatment. Second, to determine if the IVF would ultimately benefit the couple or not, and to identify the significant underlying pathology or associated medical comorbidities, and to determine if there are the age, health, lifestyle, or genetic factor that can ultimately affect the outcome or success rate of IVF if it is required. Etiology of agiospermia. Let's come to the very specific terms. The agiospermia, it can be divided into the different way. That is the site of the obstruction or the location as per the testes. And so therefore, we can classify them into the pre-testicular, testicular, and the post-testicular causes. Pre-testicular are basically any medication, tumor, disease, or disorder that can affect the pituitary gland or hypothalamus can potentially lead to the male infertility by altering the gonadotropin-releasing hormone or causing the gonadotropin deficiency. That includes the hypogonadotrophic hypogonadism. Erectile dysfunction, coital disorders as retrograde ejaculation, anejaculation, genetic factor, or chromosomal abnormalities also comes into the pretesticular factors. The testicular, which constitutes almost 60% of the cases of the agiospermia, it involves the disorder of the spermatogenesis intrinsic to the testes. It can be also seen with the severe oligoasthenoteratospermia or as a case of non-obstructive agiospermia. Hypergonadotropic hypogonadism is the usual presentation of this group of the patients. Post-testicular causes, etiology is ejaculatory dysfunction or the obstruction of the sperm delivery to the urethral meatus. They constitute almost 15% of the patients. There's still a good number of the patients where you can't find a specific cause and they can be labeled into the idiopathic. Let's come to the biggest group of the agiospermia, that is the testicular disorders. Testicular disorders can be congenital, acquired, or idiopathic. Congenital, as we are aware, that is can be because of genetic abnormalities and the Y chromosome microdeletion of major chromosomal disorders, maybe germ cell aplasia resulting to the Sertoli cell anomaly syndrome or spermatogenic arrest. Acquired are mainly the trauma, torsion, post-infectional inflammations, maybe exogenous factors like the medication, cytotoxic drugs, radiations. Systemic disorders also lead to the agiospermia, especially affecting the testes, maybe the liver cirrhosis or renal causes, and testicular tumors. Varicocele, as already said, constitute almost 15% of the male factor infertility in a significant number of the agiospermia patient. The post-testicular causes of the agiospermia, which constitutes almost 15% of the patients, the lesion of the seminal tract, inflammatory diseases, congenital abscess of the vas, post-vasectomy, erectile dysfunctions, premature ejaculation, and the use of a condom or a diaphragm can also lead to the infertility. This category would also include the bladder neck surgery, post-transrectal urethral resection of the prostate, retroperitoneal lymph node dissections, rectal surgeries, multiple sclerosis, and the antagonist medication used for a longer period. Male infertility can also be classified based on the medical intervention that can potentially assist the conception, because we are ultimately looking for the answer to the agiospermia or the male factor infertility. So we have to look for whether it is a treatable or untreatable cause. Treatable cause of male infertility are found in 18% of the cases. That includes the obstructive agiospermia, ejaculatory duct and the prostatic midline cyst, gonadotropin deficiency, sexual function disorders, sperm autoimmunity, varicocele, and the reversible effect of the toxins. The other 12% of the cases that are untreatable male infertility are seen in the cases of the primary seminiferous tubular failure, Sertoli cell anomaly syndrome, and the bilateral orchidectomy patients. There is another way, that is the uncorrectable male infertility or subfertility, which is found in 70% of the cases that include the oligozoospermia, acinozoospermia, teratozoospermia, and normozoospermia with the functional defects. And IVF will generally be necessary for the reproduction in these type of the group, this group of the patients. So our question is, what are the correctable causes where we can help these patients? The pre-testicular and the post-testicular abnormalities that causes azoospermia are frequently corrected, whereas the testicular disorders, which constitutes almost 60% of the patients, are generally irreversible, except the impaired spermatogenesis associated with the varicocele. So what is varicocele? Varicocele is basically dilatation of the Pumpernicum plexus, and they are the major veins which are taking the blood from the testes, found in almost 11% of adult male and 25% of men with the abnormal semen examination. Generally, pain, discomfort, and infertility is the common presentation associated with the progressive testicular damage and may result in the increased DNA damage which is secondary to the oxidative stress. Varicocelectomy can reverse the sperm DNA damage, but the surgery is not required in all patients. Generally is required in only where there is a varicocele of a grade 2 or grade 3, which is visible varicocele, then surgery can reverse the sperm DNA damage because of the dilatation of the Pumpernicum plexus. Oral antioxidants can improve the sperm function in these patients. Let's come to the obstructive azoospermia. Inability to detect both the spermatozoa and the spermatogenic cells in the semen and the post-ejaculate urine due to bilateral obstruction of seminal duct. They are less common than the non-obstructive azoospermia. It occurs or found in almost 15 to 20% of the male with the azoospermia. And most of the time, the obstructive azoospermic patients are having the normal FSH, normal size of the testes, and on clinical examination, one may find the abdominal enlargement of the fullness. Obstructive azoospermia can be classified depending on the location of the obstruction. It can be at the level of epididymis, the vas, or ejaculatory duct, and can be acquired or the congenital. Acquired are most of the time either in the post-surgery or because of the infection. The second category of the azoospermia is the non-obstructive azoospermia. Non-obstructive azoospermia represent almost 60% of the total azoospermic patients, and the majority of them shows a primary testicular failure due to intrinsic defect in the onset or progression of the spermatogenesis. Various testicular histology that include the Sertoli-Cell-Onley syndrome or maturation arrest at the different stages and the hypospermatogenesis can be found. In almost 60% of non-obstructive azoospermia, the etiology remain idiopathic, and that is labeled as the idiopathic non-obstructive azoospermia. Sertoli-Cell-Onley syndrome and the complete maturation arrest are characterized by the absence of the haploid cells in the testes, and hence the TACE procedure to recover the spermatozoa for the subsequent XC is unsuccessful. In case of incomplete maturation arrest, some tubules may contain the round or lateral stage of the spermatid, and that can be used later on for the diagnostic gene panel can help us, or they can be utilized later on in the XC procedures. So let's have the obstructive or non-obstructive. The idea is if it is obstructive azoospermia, so our question is whether it is operable. If it is operable, then how much is success? The surgery or the percutaneous aspiration, especially for the XC procedure, if be possible or not. In case of we are looking for a non-obstructive patient, then the question is whether any treatment can be offered to them or not, or any sperm, if it is present, can be used for the XC procedure. To differentiate between the obstructive and the non-obstructive azoospermia, estimation of the simple seminal fructose can start our workup in these type of the patients. Seminal fructose, especially you can see here, is secreted from the seminal vesicle, and this presence of the fructose can help in the primary level whether we are dealing with obstructive azoospermia or non-obstructive azoospermia. Though there is the exception when the obstruction is close to the epididymis and the vas junction, then you can have the presence of the fructose with the obstructive azoospermia. Otherwise, in the most of the cases, the obstruction is at the level of the seminal vesicle and the prostate, and you may find the volume is less and the fructose is absent. Another good number of the cases we can see in the male factor infertility is hypogonadism, which is characterized by the impaired testicular function, which may affect the spermatogenesis or testosterone synthesis. Hypogonadism can be categorized into primary, where there is a testicular failure. Secondary hypogonadism is mainly because of the insufficient gonadotropin releasing hormone secretion or gonadotropin secretions. And third is the androgen insensitivity, that is the end organ resistance to the gonadotropins. Another important form of hypogonadism is the congenital hypogonadotropic hypogonadism, which is a rare condition caused by the deficient production, secretion, or action of gonadotropin releasing hormone in the absence of anatomical or functional abnormality of the hypothalamus pituitary axis. Congenital hypogonadism is a clinical heterogeneous condition covering a wide spectrum of the symptoms. In almost 80% of the patients, spermatogenesis is induced after the long use of the gonadotropin treatment, and the mutation can be, but the question is, mutation can be transmitted either through the spontaneous pregnancy or through the ART procedure. Overall, the complexity of the disease makes the predicting exact health consequences for the offspring difficult in this group of the patient. One of the important curable causes of male factor infertility is the infection of the male accessory glands. Infection can be at the level of urethra, prostate, or testes or epididymis. The effect of chronic prostatitis on sperm density, motility, or morphology is always under debate. But the reactive oxygen species might be increased in the chronic urogenital infection, and they are associated with the increased leukocytic number. Though the antibiotic for this group of infection might provide the improvement in the sperm quality, the therapy does not necessarily enhance the probability of the conception. That must be taken care of. One more group of the patient where we label it as the idiopathic oligoasthenoteratozoospermia, a common cause of male infertility, which is characterized by the low sperm count with a high percentage of slow-moving abnormal sperms. And that comes as high as 30 to 40% of the idiopathic cases. May be explained by the endocrine disruption as a result of the environmental pollution. Maybe there is a reactive oxygen species or genetic abnormalities. We can say that environmental toxins, insecticides, fungicides, pesticides, smoking, excessive alcohol, or other chemical exposure are probably responsible for this group of abnormalities. For this idiopathic oligoasthenoteratozoospermic, what are the investigations which can help in establishing the diagnosis? The semen examination, at least we must have the two tests with us. Hormonal estimation, post-ejaculatory urine examination, especially the transrectal sonography, genetic workup. Some cases may require a specialized clinical test for the semen or the sperm that may include the culture also. Let's come to the hormonal estimation to establish the etiology of the male factor infertility. Generally, the indication is a low sperm count or a concentration or clinical finding are suggestive of the endocrine disorder or impaired sexual function. The endocrine lab test panel should include this FSH, testosterone, LH, prolactin, estrogen, or optional can be TSH. An elevated estrogen level or a testosterone-estrogen ratio, if it is less than 10, may suggest a possible fertility benefit from aromatase inhibitor to reduce the estrogen effect. Otherwise, in the most of the male patient, estrogen estimation is not required unless there is obesity or there is a sudden weight loss or weight loss or chronic systemic disorders like the renal disorder, the hepatic disorders. Otherwise, we can exclude the estrogen estimation. Most of the time, for us, the most important endocrine parameter is the FSH, and the raised FSH level is indicative of the spermatogenic abnormalities or the premature testicular failure. A male with the azoospermia with a normal testosterone, LH and FSH level exclude the obstruction by measuring the seminal fructose and obtain the urological workup. In case when you are finding the normal testosterone, normal LH and elevated FSH in an azoospermic or severely oligozoospermic male, which are suggestive of the primary spermatogenic failure, man should undergo the measurement of testicular volume, karyotyping, and the screening for the Y chromosome microdeletion. In situation where you are finding the low testosterone with a high FSH and LH, that might suggest the primary hypogonadotropic hypogonadism, which would affect both the sperm production and the testosterone level, a karyotype should be performed. A low testosterone with a normal or low FSH and an LH that may indicate the secondary hypogonadism, one must check the serum prolactin level too. Cushing's disease can be confirmed by the 24-hour urine test for the free cortisol, dexamethasone suffrage test, or by checking the midnight salivary cortisol concentrations. Thyroid dysfunctions can be identified by the abnormal serum thyroid function test and suggested by the abnormal TSH level. Normal testosterone and LH with a high FSH are suggestive of the primary spermatogenic failure, especially associated with azoospermia or a severe oligozoospermia. One must check the testicular size here to consider the karyotype as well as the Y chromosome microdeletion. A less severe form with the mild oligozoospermia might indicate the Sertoli cell dysfunction causing the reduced production of inhibin, which increases the FSH. Normal testosterone, LH and FSH. If there is a azoospermia, normal testicular size indicate the obstructive azoospermia, which can potentially be treated surgically. If associated with the bilateral absence of the VAS, this could indicate the CFTR gene mutation with or without the clinical sign of cystic fibrosis. A family history of cystic fibrosis should be obtained and both partners should be checked for CFTR gene before the pregnancy. High testosterone and LH, but normal FSH, this would be considered with the partial androgen resistance at the end of it. Then comes the role of a testicular biopsy to establish the etiology of the male factor infertility. Azoospermia or extreme oligoasthenoteratospermia in the presence of normal testicular volume and the normal FSH level, one can think about the testicular biopsy, especially to exclude the spermatogenic failure. The biopsy is aimed at differentiating between the testicular insufficiency and the obstruction of the male genital tract. Sperm in the testicular tissue may also be retrieved and frozen at the time of the biopsy. Therefore, the biopsy should be performed at the setup where the sperm freezing is available. Otherwise, a biopsy should be avoided. There is a reported discrepancy between in the finding of the testicular biopsy between the two sides. So whenever the biopsy is considered, it should be taken from both the sides. Let's come to the genetic workup of the male factor infertility. The chromosomal testing may be indicated with the azoospermia or a severe oligozoospermia. The chromosomal defects are more common in infertile male, up to 15% than in normally fertile male population. The sex chromosome, which constitutes almost 15% higher chances than, and the autosomal abnormality, which is found as high as 6 times greater than the normal population. The common genetic factors which are associated with the infertility in the males are impaired testicular function due to chromosomal abnormalities, isolated spermatogenic impairment due to Y chromosome microdeletion, and the congenital absence of VAS due to cystic fibrosis, transmembrane contact dysregulatory gene mutation. The one which is most talked about is the Y chromosome microdeletion, which is most of the time found either with the azoospermia or a severe oligozoospermia and the elevated FSH level. The Y chromosome microdeletion is most of the time depends upon the location of the microdeletion of the Y chromosome, and most of the we label them as a AZF-A, B, and the C. They are the 3 locations, and subsequently the 3 additional groups are also recognized as far as the microdeletion are concerned. Depending on the microdeletion location of the Y chromosome, A and B are considered virtually with the 0 chance of retrieval of the sperms, whereas the C are the case, the patients where one can have the retrieval rate as high as 50 to 60%. AZF-C microdeletion carriers spermatozoa can be retrieved through the micro-TSA from the testes with a success rate of almost 50 to 60%. Another common congenital abnormality which we are generally discussing is the congenital absence of the VAS difference. CABD is a congenital which is found as high as 1 in 1,000 male, characterized by the lack of both VAS. It may manifest with the various clinical features depending on the association or not with the abnormality of the male urogenital tract. Mainly in the seminal vesicle, 50% of the cases, and the kidney, the renal agents found in 5 to 10% of the patient. The prevalence in the azoospermic male is estimated to be 4 to 17% and may rise up to 25% cases of the obstructive azoospermia. A congenital absence of VAS associated with the agency of seminal vesicle is characterized by the azoospermia, low semen volume, and acid pH. Since the testicular function, the patient is usually normal. The conception of biological child is possible through the TSA with the AIT procedure. Klinefelter syndrome is another one, which is most common genetic disorder in the non-obstructive azoospermia, which is characterized by the presence of extra copy of the X chromosome. Due to this extreme heterogeneity in its genetic and the clinical presentation, Klinefelter syndrome continues to pose a substantial diagnostic challenge. Prevalence, we all know, is as high as 1 out of 600 in the newborn male infants, which can rise up to 3 to 4% among the infertile male and 10 to 15% of the non-obstructive azoospermic male. However, the vast majority of the patients, almost 64%, are still misdiagnosed or remain undiagnosed throughout their life. This extra copy of X chromosome could derive from the paternal or the maternal non-disjunction of the X chromosome. On the other hand, the age of mother, if it is coming from the maternal side, then the age of mother seems to influence the rate of Klinefelter syndrome due to post-zygotic origin. In fact, the incidence of Klinefelter syndrome was 4-fold higher when the mother aged 40 were compared to those aged less than 24 years. Klinefelter syndrome has a wide spectrum of clinical manifestation, which may include the classical pictures such as nucleoid diabetes, hypochondropic hypogonadism, gynecomastia, small volume from testes, azoospermia, and the pervasive neurocognitive cognitive deficit. Spermatozoa can be harvested in 34 to 44% of these patients with the conventional or the micro TSA. The retrieval spermatozoa can be used for the ICSI procedure with the average live birth rate per cycle of 29% to 43%. So coming to the conclusion of the etiology of the male factor infertility, the male infertility is a heterogeneous, multifactorial, and the complex disorder of the reproductive system. And to establish the etiology, a multidisciplinary approach is required. Thank you.
Yeah, you all can put your questions in the chat box. So we still have more than 15 minutes.
Okay, I thought, ma'am, it's a 30 minutes presentation, so I tried to make it as.
Now we made it 1 hour.
Okay. Because the time given was for the two topic was 1 hour total.
No.
5 to 6. Yes.
No.
Oh, sorry.
Now, actually first 3 years when I did it was 1 hour. Then last year I didn't basically do anything. These people were doing, so they had made it half an hour. But again, I've made it 1 hour now. If you want to tell them anything else, you can also tell them what the issue.
Mainly, what we are looking for is non-obstructive azoospermic male because they are constituting almost 60% of the azoospermic patients. And there, most of the time, we lead to the misdiagnosis or the overdiagnosis of the patient. So a simple clinical examination can help us in establishing the diagnosis of non-obstructive azoospermia. Then it becomes easy not to unnecessarily prolong the investigation and go with the other options available to them. That is the most important, I feel, because obstructive azoospermia is easy to diagnose. A simple seminal examination, most of the time, a simple routine clinical practice person can check the presence of the volume of the semen. If it is less than 1 ml, pH is less than 7, or absence of the fructose. If it is reported there, one can easily diagnose whether it is obstructive or non-obstructive. In most of the cases, exceptions are there, but in most of the cases. And then a routine clinical examination of testes, where one can examine the fullness or turgid epididymis, then it becomes easy to label them whether it's obstructive azoospermia, where we can have the higher success of either the microsurgery, that is the vaso-epididymal anastomosis, or retrieval through the either epididymis or through the testes.
So there's a question, is there any role for antioxidants in severe oligoacidoteratozoospermia, or directly one should proceed to ART?
It will be too early to say whether they are really effective or not in the cases where there is a direct indication like presence of the varicocele or the chronic conditions which are leading to the, you can say, either there's a metabolic disorders or chronic physical disabilities. There, the role of antioxidants is significant. Otherwise, is empirical most of the time what we have seen, and generally we have to go directly. Either one has to buy time, then can be done for at least 3 months. Before 3 months is difficult because spermatogenesis takes place almost 90 days, 72 plus 15 days at the epididymis. So before 90 days is difficult to predict the outcome of the benefit of antioxidants. But if we have a known cause, like the presence of infection or a stress factor, maybe the presence of the chronic use of the pesticides or the fungicides or the petroleum film industries people, or they are in the chronic stress for a long, there we can think about some benefit, otherwise difficult.
The sperm DNA fragmentation, anyway, I'll be discussing. So they're asking for the days of abstinence before collecting semen sample. Hello, Dr. Sanjay. The abstinence has to be 3 to 4 days. And the semen analysis should be repeated after 1 month. Whether we do hormonal workup and all will depend upon the clinical examination. I think it's frozen. Depends on the clinical examination. And if you find that the testicular size is small, the testes are softer, and if any other factor is present, then you need to go for hormonal workup. Today, many patients do complain of anejaculation or erectile dysfunction. In this group of patients, it's important to do the estrogen as well as the testosterone levels, because many a times the estrogen levels are high, you could have erectile dysfunction, and in these patients, anastrozole is an important drug that can be used. Ultrasound then is indicated only when you are suspecting something in the scrotum. So after you've done the clinical examination, you feel the patient has varicocele, or the testicular size is small or larger, or the patient has hydrocele, then probably one has to go in for an ultrasound. The count is 28 million. When you say it is 28 million, that is the sperms what you're counting. And the spermatids are totally different. And they could be part of, which basically they could be round or elongated. So they're not counted as sperms. Semen culture is only suggested when you feel that the color of the semen has changed or the WBCs are more. And here it's important to differentiate between WBCs and round spermatids, because many a times round spermatids are mistaken as WBCs and the patients are subjected to culture and antibiotic therapy.
Sorry, ma'am, I just lost the connection in between now.
Yeah. No, so you got frozen. Anyway, I answered some of the questions. You can answer the remaining. So how to summarize obstructive and non-obstructive azoospermia, they're asking.
It's very easy. As I said, ma'am, the simple is first to go with the semen examination, where you can have the 3 major parameters to be checked: the volume, pH, and the presence or absence of the fructose. Then comes the clinical examination, depending upon whether you can palpate the vas and epididymis. If the vas is present and you can palpate the fullness or empty epididymis, then it's become very easy to differentiate between the obstructive azoospermia and non-obstructive azoospermia. And if the testicular volume is the last one to check, if the volume is normal, male is fully developed with the secondary sexual character are well, and the vas is palpable, then most of the time you can say it's a non-obstructive azoospermia where the secondary sexual character are well developed, vas is palpable, testicular volume is normal, So we can directly say, okay, yes, we are looking for, and accordingly one can plan the subsequent investigation, maybe the hormonal estimation and the testicular biopsy.
Yeah, so they're asking in azoospermia, should the semen analysis be repeated after 4 weeks?
Yes, a single semen examination should not be considered as the decision maker tool. At least the two sample must be examined, and both the sample must be examined after the making the pallet.
So is karyotyping a must in all cases of severe oligo and azoospermia?
No, it's not, because it doesn't going to help a lot. One must establish the other factor too, like the endocrine estimation must be taken care before jumping only on the genetic causes and the systemic disorders.
Basically, more it should be a Y deletion should be done, because especially in patients with azoospermia, because a Y deletion will tell us whether there is any possibility of obtaining sperms from a testicular biopsy. So it is only the C variety wherein you can obtain, whereas in Y deletion A and B, usually the sperms are not obtained. So if you have repeated implantation failure, repeated pregnancy loss, many a times there could be translocations in these patients, and at that point, a karyotyping is a must. Otherwise, when you are suspecting basically either XX or Y or XYY, then also karyotyping. Otherwise, normally a karyotyping is not necessary.
Not required.
Any other questions you all have? We still have time, so you all can post your questions.
Most of the time, the male factor infertility is idiopathic, which is very high number of the patients are idiopathic. So it becomes very difficult to establish a etiology or to treat them. Ideally, these patients must be examined thoroughly, must be talked with them, so that one can know their environmental factors, responsible lifestyle factor, because they play an important role in this group of patients, especially.
After
There's one more. Yes.
varicocele surgery, for how many months we have to wait to see changes in the semen report?
Yes. As such, any surgery of the testes, we must wait for 3 months, because as we know, the spermatogenesis takes close to 90 days. So after the varicocele surgery also, one must take. But in case of mild to moderate oligoacinospermia, even after 45 days, one can see a good change in the seminal parameters. But ideally, we must guide the patient minimum 3 months and can be up to 6 months to 1 year.
Then patients of azoospermia, how to proceed? I think no effective of sildenafil. I don't know what they've written.
As far as azoospermia is concerned, ma'am, is already we have discussed. That is, we have to see first of all whether it's a azoospermia or not. So a palate should be examined of the semen properly. At least 2 samples must be examined. Then we have to establish whether it's a obstructive or non-obstructive. By the same semen examination can help us, and you can add the clinical examination. Once you have established whether it's a obstructive or non-obstructive, then we have to establish whether it's a correctable, treatable cause or not. If it is a treatable cause, especially in case of obstructive azoospermia, then we have to look for the whether it's a recanalization surgery or the surgery for the microsurgery for the establishing the vas patency, or if there is some cyst in the prostatic urethra, or there is a posterior wall urethra, then these can be done through the corrective surgeries. Otherwise, we have to look for the direct aspiration of the testes for the sperms if the patient is willing to go for ART procedure.
The role of letrozole in male infertility. I think that was discussed there, on the Monday actually when we are discussing. But you can tell anyway. So, okay.
As such, only 2% of the hypochondropic patients where one can think about the use of a hormonal supplement to the patients. Most of the patients are, one should not write the hormonal preparation unless well established. Because the FSH level, if they are normal and you are adding some FSH or gonadotropin stimulating drug, it's definitely going to have the as the traditionally we have gone through, that will lead to the suppression of the spermatogenesis. Ideally, we say it is a rebound effect which can help us in getting the normal spermatogenesis, but may not be possible in most of the patients. So that must be warned before writing the either.
But it's also used when the testosterone and estradiol ratio is altered. So you use
Yes.
aromatase inhibitors in those cases.
Especially when you are looking for a high estrogen conditions, there yes, it can.
So they're also asking where we don't have trained andrologists, whom do we refer the patients to? You can refer to a urologist, I think, if
Yes.
you don't have a trained.
Andrologist, yes.
So in azoospermia, they're asking whether PISA is the line of treatment.
Only in the conditions when you can see the palpable epididymis, especially in the obstructive azoospermia and the palpable epididymis, then the percutaneous aspiration, yes, is very helpful. You'll get a good sample and can be used in the ART procedure.
So 16-year-old boy left orchidectomy done due to malignant lesion. Before subsequent chemo, he was advised semen freezing, but reports was azoospermia. Can age be a reason?
It can be if the other secondary sexual character are not well developed.
Yeah, 16 years is borderline. Normally in a 16-year, you would find
Yeah,
sperm. But if it is not there, then it's best to check his FSH levels, because his FSH levels will reveal to us whether there is normal spermatogenesis or not. Because if the FSH levels are high, then you know that it's testicular failure. And therefore, then the chances of obtaining sperms by any method is diminished. Can a trained gynec do PISA?
Require a practice. The simple aspiration of the, but only thing is one has to understand how to hold the epididymis in the hand and to stabilize the needle and to aspirate. It requires a regular observation with the person, those who are doing and the train. They can do it. Many of the seniors, they are doing.
If you don't know properly, you can injure the testicular tissue if you
Or
don't
you can
know
lead to the
properly,
hematoma formations.
and result in fibrosis. I think probably is test TISA advisable, or do you have to do on the day of OPU?
No, it should always be done before starting the ART procedure, so that you are sure that you are going to get the sperms while when you are going to require them. Otherwise, it may create a unnecessary confusion or the lot of dilemma to the patient.
Yeah, so
Best
when
is
you're
to be done
doing the,
before.
when you're doing the trial TISA, whatever sperms you get, you must freeze them. So many a times, just you can use the same sperms, and there's no need for you to repeat the TISA procedure. If the patient has erectile dysfunction or ejaculatory issues and is not able to give a sample, sildenafil not working, how to proceed with the semen analysis for the patient, and should we proceed with PISA?
Not ideally, PISA should not be considered here at this stage. Either a proper counseling with the maybe the sexual consultant or use of the vibrators to get the ejaculation. In the case of extreme condition, one can use the vibrator. You can say the nowadays we are not using. Otherwise, the one can have the under GA the prostatic stimulation, and one can get the seminal ejaculate.
Or one can also do a postcoital test. You tell, if
Yes.
you cannot obtain a sample, you can tell the patient to have intercourse. You call her the next day, and you can aspirate the cervical mucus, and you can look under the microscope, and the presence of sperms will tell you that the patient has normal spermatogenesis.
Previously, the PCT was used to be very common test, ma'am. Nowadays, I think we are not talking about it because of the many reasons. But yes, to confirm the presence of a sperm is very good.
Still has a role. I still do it in my practice, though it
Yeah.
does not have a positive and negative predictive value. But if you have a negative, probably a postcoital test, then you can proceed with IUI much earlier than waiting for
Yes.
3 to 4 months of trial with timed intercourse.
But this is good in the case of if the male is failed to deliver the sperms in the lab or in the hospital setup, it is good to go through the PCT. So it becomes very easy. before we end, I'll say two things here, ma'am. One, in general, the people must not go for a testicular biopsy immediately whenever someone is saying there is azoospermia or a severe oligoasthenospermia, and we generally advise them to go for a testicular biopsy. It should be avoided because injury to the testes will ultimately lead to more fibrosis and the formation of antibodies. And you may, if there is a sperms available later on, when really they are required, we can't use them. So it should be after proper workup and thorough counseling, especially guiding them if it is required, then they must plan for ART procedure, then the biopsy can be given. Second, the empirical use of clomiphene citrate or other gonadotropins in the case of severe oligoasthenoteratozoospermia or oligospermia should be avoided because many times we fail to get whatever the sperm we are getting, they will undergo the permanent suppression or failure.
Right.
The FSH level must be known to us before starting any of these medications.
Especially all these drugs should not be given if the FSH level is more than 8. Basically,
Exactly.
they're all useful only when there is hypogonadotrophic hypogonadism and not when there is hypergonadotrophic hypogonadism. So having low levels of, even for clomiphene citrate, having low levels of FSH is very, very important. And in patients with oligospermia also, they really don't really much help, but then you can give a trial that also when the FSH levels are low. If there are no more questions, we can move on with the next lecture. They're asking role of stem cell injection in severe oligospermia. Sanjay? I think it's frozen again. There's no role as yet of stem cell injection in severe oligo or azoospermia. So we had different, the semen analysis has changed quite a bit in the WHO Manual 21 from the previous manual, which was published in 2010. So we know that a sperm is a sophisticated toolbox, which is an optimally elected cell with high quality DNA, centrosome, RNA species, histone code, and many unknown factors. And during its incredible journey, selection of the best sperm at the site of fertilization is very important for conception to happen. And the sperm characteristics that are important for fertilization are the normal morphology, intact chromosome, acrosome, straight line velocity and linearity, ability to bind to the zona pellucida, penetrate the zona pellucida, fuse with the ulema, activate the oocyte, and its ability to form a pronucleus. So we know that semen analysis is basically the basic investigation to evaluate the male fertility, and it should be done with 2 to 7 days of sexual abstinence according to the WHO manual. But most of the infertility clinics believe that it should be done with an abstinence of 3 to 4 days. It should twice separated by at least 1 month if it is abnormal. And whenever a semen analysis is done, following should be repeated on the container. That is the name and the personal code number, the period of abstinence, the date and time of collection, as well as the completeness of the sample. So when we talk about the collection, can you mute yourself? Kalyani, please mute yourself. The samples obtained by masturbation and ejaculated into a clean container made of glass and glass or plastic, which is non-toxic. The semen specimen container is then placed on a bench or in an incubator at 37 degrees centigrade while the semen liquefies. The sample is examined 30 to 60 minutes after ejaculation. For microbiological analysis, specimen containers and pipettes must be sterile. Analysis should be done as per SOP. Dr. Kalyani, please mute yourself.
Priya, please mute Dr. Kalyani.
Collection of semen at home is should not be done. Collection of semen by non-toxic compound during sexual intercourse can be advised if the patient cannot collect the sample by masturbation. Coitus interruptus should not be practiced for getting a semen sample. And it's important that you use the safe handling methods of the specimen in patients who have infection like HIV. The result of the semen analysis will depend on whether a complete sample is collected or not, whether the first part, which is rich in the sperm portion of the ejaculate, has been collected. We need to also look at the activity of the accessory sex glands, the time since the last sexual activity, any difficulties in producing the sample, and the interval between the collection and start of semen analysis. So basically, what is the difference between the 2021 manual? So in 2010, the samples basically were analyzed only from Australia, Norway, USA, Denmark, Finland, France, United Kingdom, and Denmark. Whereas in the 2021, apart from this, China, Egypt, Greece, Iran, Italy were also included when the manual was prepared. Please mute Dr. Kalyani. So what do we look in this semen analysis to know the pathology of the sample? So the first is liquefaction. Nilima, please tell them not to mute her.
Shreya, why don't you do something?
मैम
norm-
एक्चुअली उनके यहाँ से ही है वो प्रॉब्लम।
अरे पर उनको म्यूट करो ना।
मैम कर रही हूँ तो वो वापस से अनम्यूट होते जा रहे हैं, मैं उनको ये कर देती
नहीं तो
हूँ।
उनको फोन करके
तो-
बोलो, नहीं
यस
तो
मैम, यस मैम।
को बोलो,
एग्जिट कराओ।
हाँ
Exit-
मैं करवाती हूँ।
लेक्चर छोड़ने को बोलो, नहीं तो अगर उनको नहीं
हाँ।
सुनना है तो।
हाँ मैम।
क्या है, इंटरप्ट होता है ना बात करते समय।
Okay, ma'am.
So basically you need to look at the liquefaction. So normal semen sample normally liquefies within 15 to 20 minutes. If liquefaction is delayed for more than 30 minutes or does not occur at all, one should report it in the final report. And this may be due to abnormal prostatic function due to an infection in the genital tract, prostate, or seminal vesicle. It could be as an artifact as a result of use of unsuitable type of plastic containers. And it is also seen in those men who have frequent ejaculation. The volume is normally between 1.5 to 4 ml. Low volume is seen in patients who have obstruction of the ejaculatory duct due to previous infection of the genital tract, congenital absence of the seminal vesicle and vas deferens, and this is associated with absence of fructose in the semen sample, and therefore testing for fructose is very, very important. Retrograde ejaculation, especially with history of previous surgery or prostate or bladder neck, loss of fraction of the ejaculate, the first part of the ejaculate during collection, and also in those patients who have androgen deficiency. The pH is normally 7.2 or more. And if it's more than 8, basically it could be because of acute prostatitis, vesiculitis, or bilateral epididymitis. If it is less than 7.2, it's as a result of chronic infection. And if it is less than 7, there could be obstruction of the ejaculatory duct, congenital bilateral absence of the vas deferens in the presence of azoospermia, and cases where only the prostatic fluid is being secreted. So coming to how do we do the semen analysis? So basically all the semen samples are allowed to liquefy for 30 minutes at 37 degrees centigrade. One could use either a hemocytometer or a Maker's chamber. The central grid, which consists of about 25 large squares, sperm should be counted in one of the 25 squares of the central grid, which is bound by a triple line and contains 16 small squares, as it has been shown over here. The sample has to be diluted and less than 10% spermatozoa count, less than 10 spermatozoa count in the whole grid of 25 large squares. 10 to 40 spermatozoa usually should be counted in the 10 large squares, and more than 40 spermatozoa should be counted in 5 squares. Whereas in a Maker's chamber, you don't require to dilute the sample. You need to put the sample on the Maker's chamber and cover it with the cover slip. And it has 100 grids. There are 10 in each line. So in the presence of normospermia, you need to count the total sperms in the any of the 10 grids across. Then you need to note down how many of them are rapid linear, slow linear, non-progressive and progressive. And then out of that, you need to calculate what percentage of motility is rapid linear, slow linear, non-progressive and immotile. You need to make slides for the morphology as well as viability. So so if you look at the sperm numbers, so in the 2010 manual, it was 15 million per ml, and in the 2021, it's 16 million per ml, whereas the total per ejaculate has remained the same, which is about 39 million per ejaculate. In the presence of low or absent sperms, examination of the sediment of the centrifuge sample is essential. So if there are no sperms seen, you need to centrifuge the sample, you remove the supernatant, and you mix the pellet with culture media, and that you examine under the microscope. If there are presence of spermatozoa, we can diagnose cryptozoospermia. And in the absence of spermatozoa, we have to suspect azoospermia. But as I told you, it's most important to repeat a semen sample. Coming to sperm motility, there are 4 types of motility. One is progressive or rapid, where the speed is more than 25 micrometers per second. Slow progressive, where it is between 5 to 25 micrometers per second. Non-progressive is when it's less than 5, and immotile. So according to the WHO 10, that is A plus B plus C should have been more than 40, and A plus B should have been more than 32, whereas in the 2021, A plus B plus C, now they said have to be more than 42, whereas A plus B can be more than 30% as normal. And as I said, that's how it is calculated. It's 100 into total number of sperms with particular type of motility divided by total number of sperms. Coming to vitality, one should evaluate at least 200 spermatozoa. The slide should be stained by uracil nigrosine stain, and the sperms with red or dark pink heads are dead. Because of they're dead, the dye can penetrate inside because the membrane is damaged, whereas those with white heads, as you see over here, are supposed to be alive. According to the WHO 10, it was 58% should be live, but according to the 2021 edition, it is more than 54% that should be live. Sperm morphology is basically studied either by papinecular stain or by Schur's stain, and it can also be studied by computer-aided morphometric assessment. Normally, in ART clinics, most of us use the Kruger's criteria, where we say that more than 14% have to be normal, whereas according to the WHO guidelines, it is more than 4% that needs to be normal. So each spermatozoa is evaluated as normal or abnormal, and the percentage of normal sperm cells in the ejaculate is evaluated and related to the fertility according to the threshold. So you can have abnormalities in the head, which include a tapered, a pyriform head, a round head where there is basically absence of acrosome. There could be amorphous head, vacuolated, as well as small acrosomal area is seen. There could be neck and midface defects where you could have a bent neck seen, asymmetrical neck, thick insertions and thin insertions. There could be tail defects where it could be short, bent or coiled. And there could also be excessive residual cytoplasm which is seen. So basically, as I explained to you, these are the abnormalities that can be seen. So acrosome in the head, acrosome less than 40% or larger than 70% of a normal head area. Length to width ratio, which is less than 1.5 or larger than 2. Shape, which is pyriform, amorphous, asymmetrical, non-oval in the apical part. As I've already showed you in the picture, there could be vacuoles, double heads, or any combinations. In the midpiece, basically irregular shape, thin or thick, asymmetrical or angled insertion at the head, sharp bent or any combinations. The tail could be sharply angulated or bent, smooth hairpin bends, coiled, short, irregular with multiple tails, as well as any combinations. And as I told you, there could be cytoplasmic residue. So this is a classification which is there in the WHO Manual 2021, which I have sent it to all of you all yesterday. Then it's very important to count the cells other than the spermatozoa. The semen cytology, basically you have to look for the white blood cells, which include the polymorphs, epithelial cells, histocytes, and ghost cells, and they should be less than 0.5 to 1 million per ml. Round cells or the immature spermatozoa should be less than 5 million, and it is the peroxidase activity, or which is a leukocyte marker, which differentiates between the WBCs from the immature cells, and this is done by using orthotoluidine dye. And we can also use the pan-leukocyte CD45 immunocytochemical staining. And presence of increased WBC suggests accessory gland infection. And if peroxidase positive granulocytes are more than 10 million, one must advise a semen culture. So as I said, sperms cells other than spermatozoa include the immature germ cells like the spermatogonia, spermatocyte 1, 2, the round spermatids as you see over here, and elongated spermatids. Then we also need to look for different types of agglutination. And we know that there are two types of agglutination. One is non-specific, where the sperms adhere to the cells or debris which is present in the seminal plasma. Whereas specific agglutination, which is caused by anti-sperm antibodies, which can be where there is head-to-head adhesions. And this can be detected by either by the immunobead test or the mixed antiglobulin test, which has to be less than 50%. As the 2021 manual has shown that there could be different types of agglutination. One is head-to-head, tail-to-tail, tail also as seen in more clear of agglutination. They could be tail tip to tail tip. They could be mixed, that is head-to-head and tail-to-tail. And they could be also tangles, as you can see over here. So the incidence of agglutination is about 10% in the infertile population and can vary anywhere between 3 to 20%, whereas in the fertile men, it is usually 2% or less. We also need to look at the semen biochemistry, which is going to assess the accessory gland function by evaluating the fructose from the fructose for the seminal vesicle, zinc and acid phosphatase from the prostate gland, and alpha glucosidase, GPC, and L-carnitine from the epididymis. One must then know that the occurrence of pregnancy not only depends upon the sperm number and but it also depends upon the oocyte quality and the sperm quality, which is results in embryo quality and which is responsible for successful pregnancy. One must also have a normal endometrial receptivity, and correct diagnosis of the male factor should be made and the best sperms should be selected. And therefore, it is important to diagnose any sperm dysfunction if it is present. So we know that semen analysis is an essential part of infertility investigations, but it has limited diagnostic value for male infertility and prognostic value for ART, because routine semen parameters exhibit a high degree of variability, tell us about the function of the testis, but fail to predict sperm chromatin quality and sperm function. They are modest predictors of male fertility potential, have low prognostic value, and the current WHO standards fail to meet the rigorous clinical and statistical standards. Therefore, we need better markers of male fertility potential than the conventional sperm parameters, which will more accurately diagnose male infertility, to identify markers that can predict reproductive outcome after ART, and conventional parameters, because conventional parameters are not predictive, and also to evaluate the influence of sperm DNA damage on the health of IVF and ICSI children. And therefore, we require the sperm function test, and these include the hypoosmotic swelling test, a detailed sperm morphology including teratozoospemic index, a trial wash to determine the quantitative and qualitative yield with sperm survival, to look for anti-sperm antibodies, computerized aided sperm analysis, mucus penetration, which we normally don't see, but it can be made out in vivo by doing a postcoital test, the sperm DNA fragmentation, and evaluation of the reactive oxygen species, which is lipid peroxidation that can affect fertility, when it affects the midpiece, it can affect the motility. When it affects the acrosome, the gamete binding, and when it affects the sperm head, there could be DNA damage. So coming to the hypoosmotic swelling test. So here we need to evaluate 200 sperm. Information on it gives us information on the membrane integrity of sperms, and there is a good correlation that exists between the spermatozoa showing positive HOS and fertilization rate or IVF. In the WHO manual, it should have been more than 60, whereas in the 10 and the 2021, it is more than 50. So what are the HOS positive sperms? So those sperms which curl over here, as you can see, the tails which have curved are supposed to be HOS positive. This is HOS positive, this is HOS positive, whereas this and this is HOS negative sperm. So its main use is to identify viable sperms when sperm samples show 100% immotile sperms. When you're doing an ICSI, many a times they are viable, but they are non-motile. We can use this to identify a viable sperm for injecting into the oocyte. So if the HOS is more than 60, patients can benefit with IUI. Borderline 50 to 60% is a gray zone and may be subjected to IVF if the post-wash count is at least 10 million. And if they are abnormal, usually these patients will benefit with ICSI. Patients with good count and motility but less than 50% HOS positive sperms result in fertilization and cleavage with IVF, but the surface toxins is transferred to the zona pellucida, which can prevent implantation, and therefore ICSI is preferred in this group of patients. Then coming to the teratozoospermic index, which is a good predictor of the fertilization rate as well as the pregnancy rate. It is a multiple anomalous index. So you need to count total number of 100 sperms. We have to record how many are normal and how many are abnormal. And in the abnormal, each sperm can have maximal of 4 defects. So the total number of all separate abnormalities is then divided by total number of abnormal spermatozoa that are counted, and that gives us the TZI index. So because one sperm can have more than one defect, that one must remember. So normally it should be less than 1.6, and if it is more than 1.8, ICSI is advocated irrespective of the count and motility. Now, the 2021 manual, sister, I want some water. Is also have put apart from the TZI, they have the SDI and the AMI, and they have written how do you count them. So total number of spermatozoa counted. Then you have to look at the normal spermatozoa. What is the percentage? Number of spermatozoa with defects, you need to pen down. Then number of head defects will tell us about the MAI, SDI, or the number of spermatozoa with more than one head defects, that is the TZI index. Number of mid-piece defects is going to tell us about the MAI, or number of spermatozoa with more than one mid-piece defect is going to tell us about the TZI index and SDI. The number of principal piece defects or the number of spermatozoa with more than one principal piece defects is going to tell us about these abnormalities. And the number of spermatozoa with excessive residual cytoplasm also should be evaluated. So total defects is equal to 1 plus 2 plus 3, which is equal to 6, and that is going to tell us about the MAI. Whereas the total, the 1 plus 2 plus 3 plus 4, which is equal to D, is going to give us idea about the TZI index and the SDI. So the index values, as I told you, for MAI, it is 2.55. TZI, initially it was 1.6, but now according to the new manual, it is 1.72, and the SDI is 1.62. So how is it calculated? The MAI is calculated by dividing C by B. That is, B is number of the total sperms with defects. The TZI is calculated by D, that is all the 4 defects, which is then divided by the total number of sperms with defects, whereas the STI is calculated by D, which is divided by total number of sperms that have been counted. So then coming to the computerized assisted sperm analysis, which is a semi-automatic technique. The advantage is that it has high precision, quantitative assessment of sperm kinetics. It provides data on sperm density, motility, straight line, and curvilinear velocity, linearity, and average path velocity, amplitude of lateral head displacement, as well as flagellar beat frequency and hyperactivation. But one must remember that it is not superior to semen analysis, conventional semen analysis, and the evidence for it is grade A. So what are the disadvantages of CASA? One is that the sperm concentration, sample preparation, and frame rate can affect the accuracy of the CASA. Stains used also affect the accuracy of determining the morphology. It does not add any advantage in clinical practice. It requires expensive equipment and still requires the active participation of a technician. Coming to reactive oxygen species, we know that it is both good and bad. And small amounts of ROS are necessary for spermatozoa to acquire fertilizing ability, and the sperm physiological processes such as capacitation, acrosome reaction, hyperactivation, motility, and sperm oocyte fusion. One needs to have ROS. So it is good. It is bad because especially in the presence of axillary gland infection, where there are presence of leukocytes in the semen sample, in the presence of varicocele, abnormal lifestyle like obesity, I want some more, and diabetes, cancer, immature sperms, and presence of dysfunctional sperms increases the ROS, which results in oxidative stress, which then results in lipid peroxidation. And as I told you, when it affects the mid-piece, it affects the motility. When it affects the acrosome, it affects the gamete binding. And when it affects the sperm head, it results in DNA damage. There are several factors which contribute to the oxidative stress in the male, and I think this was already discussed by Dr. Sanjay Makwana. So basically, it could involve the male accessory gland infections, prolonged stress of spermatozoa in the epididymis or its transit, immature or abnormal spermatozoa. Then there could be systemic pathologies like diabetes, cancer, systemic infection. The use of mobile phone radiation is a very important factor resulting in oxidative stress. Then you have environmental and lifestyle factors like drugs, smoking, pollution and radiation, obesity, and mobile phone. This all results in sperm dysfunction and infertility, and therefore probably evaluation of oxidative stress may be important so that the treatment, and this should include the treatment of the underlying pathology, antioxidant supplementation, and avoiding factors promoting the reactive oxygen species generation. This oxidative stress then contributes to the defective spermatogenesis and sperm function, leading to male factor infertility. And you can clearly see over here, if you look at all these samples, the oligoisomospermic samples have a significantly lower total antioxidant capacity as compared to those with acinospermia and normozoospermia. There are certain laboratory signs suggestive of possible sperm oxidative stress, and this includes poor sperm motility, teratozoospermia, high number of round cells like leukocytes in the semen, increased semen viscosity, poor sperm membrane integrity on a hypoosmotic swelling test, poor fertilization on routine IVF, poor sperm motility after overnight incubation with the oocyte, poor blastocyst development in the absence of clear female factor, like advanced maternal age and poor ovarian reserve. There are various direct and indirect assays to measure the ROS in human sperm. The direct assays include accumulation assay, nitroblue, tetrazolium test, cytochrome C reduction, flow cytometry, and electron spin resonance, whereas there are other indirect tests like the use of myeloperoxidase test, measurement of redox potential, lipid peroxidation levels, chemokines, as well as measurement of the antioxidants present in the semen. So the chemoluminescence which measures the total seminal ROS can be used, or what we use today is the leukocytospermia, which is associated with increased ROS levels and can serve as an indirect measure of ROS in our labs. The other methods which are discussed are basically only for research levels. The normal ROS level in a washed sperm suspension ranges from 0.10 to 1.03, 10 raised to 6 CPM per 20 million sperms. But these cutoff values are still not been, they're not been evaluated in all samples, and there's no exact reference range which is still available for the ROS levels. And therefore, probably it's not the mainstream of investigations, as the normal or reference values are not established at this point. Use of seminal WBC levels as a basis of ROS level, although proven and well accepted, has yet to be established definite cutoff points. Even low WBC levels are associated with ROS. And as the standardization of the testing and availability of these tests remain limited, it will be some time before this test will be, which will become a part of regular evaluation for male subfertility. And we know that oxidative stress is also a major cause for DNA damage, because we know that paternal factors are important for embryonic development. As you can see over here, DNA integrity is very important for the development of the embryo. You also have the other structures like the DNA methylation, the chromatin architecture, the RNAs and sperm mitochondria are also form an important portion for normal development. And these can be influenced by the paternal age, environmental exposure, lifestyle, as well as obesity. Is the sperm then DNA fragmentation evaluation useful? And the answer is both no and yes, because the basic semen analysis basically gives us information only about the messenger, but the sperm DNA integrity reveals information about the message. The sperm chromatin, which is a combination of DNA and protamines, and we know that the head of the sperm lacks cytoplasm, and therefore there's no transcription and no repair, and high lipid content, unsaturated fatty acid result in susceptibility to the damage to the DNA of the sperm. It is seen in the form of alteration in the chromatin structure, DNA fragmentation, DNA oxidation, as well as protamine deficiency. Infertile men have a higher level of sperm DNA chromatin damage than the fertile men. And the major mechanism of DNA damage in the spermatozoa is during the production of the sperms, as you see over here, in the testis itself. And this is basically related to the apoptosis during spermiogenesis and DNA strand breaks during the spermiogenesis. And it can also be related during its transport of the these sperms in the epididymis and vas. And basically, it could be related to post-testicular DNA fragmentation, which is via the reactive oxygen species, or it could be related to DNA fragmentation, which is induced by endogenous capsase as well as endonuclease enzyme, DNA damage induced by the radio and chemotherapy, and also by the environmental toxins. So there are 4 methods of detecting sperm DNA damage: the COMET assay, the tunnel assay, the halo assay, which is the sperm chromatic dispersion test, and the sperm chromatin structural assay, of which the tunnel and the COMET assay have more sensitivity and specificity. So when we have done the DNA fragmentation, if the DNA fragmentation is less than 15%, there's a high fertility potential. Between 15 to 30%, there's good to fair fertility potential. Whereas if it's more than 30%, there is low to poor fertility potential. Fertile men with normal semen parameters have low levels of DNA breakage. Infertile men, especially those with abnormal semen parameters, have increased DNA damage. And it has been observed that 8% of infertile men have an abnormal DNA integrity despite having normal semen parameters, that is, having a normal count, motility, and morphology. The high levels of sperm DNA damage have some correlation with oligospermia, poor motility and morphology, oligoasthenoteratozoospermia, cytoplasmic retention, as well as mitochondrial DNA damage. There's also evidence linking sperm DNA fragmentation to poor reproductive outcome, and it has an impact on the embryo and blastocyst development, progress of pregnancy and pregnancy loss. It can also have impact on the health of the baby born, and it has been seen that there's an increased incidence of dominant genetic mutation resulting in achondroplasia and Apert syndrome. There could be neurological disorders like schizophrenia, autism, and bipolar disorders, diseases and birth defects wherein there could be neural tube defect, epilepsy, Huntington's disease, as well as Down's syndrome. And here you can clearly see that there is increase in the incidence of recurrent pregnancy loss when there is higher DNA fragmentation index. And if you look at the relationship between the sperm DNA damage and pregnancy, in IUI, there's a strong negative effect. In IVF, it has a mild negative effect, whereas with ICSI, there is no effect. Thus, increased intervention from IUI to IVF to ICSI, the lesser the impact the sperm DNA damage has on early fertility checkpoints. But in IVF and ICSI, pregnancy loss can still occur, and the DNA damage has a moderate positive effect on pregnancy loss. Thus, poor quality sperms with high DFI can result in reduced fertilization rate, embryo development, implantation rate, clinical pregnancy rate, live birth rate, and there's also an increased incidence of post-implantation loss and malformation, as well as it can affect the child health. Thus, sperm DNA testing is a useful adjuvant to semen analysis for routine fertility management and may contribute to the development of the novel and more personalized approach to test and treat the male factor infertility. We have much to gain and nothing basically to lose. But why the effect of DNA damage in sperm on ART outcome is a mixture of damage itself plus the oocyte's ability to repair, and therefore probably though ART can decrease the effect of DNA damage, it should be done before an ART procedure. If we do not test for DFI and a traditional test prevail, it will prevent an improvement in a success rate in the diagnosis and treatment of male factor infertility. So then what are the indications for DNA testing? So basically, it should be performed in the presence of unexplained or persistent infertility, failure to conceive after 5 to 6 cycles of IUI despite good count and motility, low fertilization rates or poor embryo quality in an IVF cycle, implantation failure after IVF, recurrent miscarriage, prolonged stay in an environment that exposes to reproductive toxins, abnormal semen analysis, as well as advanced male age of more than 45 years. The other sperm function tests include an acrosome reaction, which is detected by using specialized staining techniques like the triple stain, trypan blue, fluorescent lecithins, and antibodies. The rates of spontaneous acrosome reaction and acrosome reaction induced by agents such as calcium ionophore and progesterone have also been measured. Sperms from infertile men tend to demonstrate higher acrosome levels spontaneously, but lower levels in the presence of inducers. It is labor-intensive and expensive and therefore not done routinely, may be recommended in cases of profound abnormalities of the head morphology or in unexplained infertility and repeated IVF failures. One could also do an acrosin activity test, which is, and we know acrosin is a serine protease-like enzyme that exhibits a lecithin-like carbohydrate binding activity to the zona pellucida glycoprotein. Low acrosin activity has been associated with low sperm density, motility, as well as poor normal morphology. Then we can do certain biochemical tests like the creatinine kinase test, which is a rapid, inexpensive, and readily standardized diagnostic test. and it is an enzyme which is involved in energy production and utilization by the sperm cells via modulation of the ATP production. Creatinine kinase is a marker for sperm maturity, which correlates with the sperm fertilizing capacity. Elevated levels of creatinine kinase are associated with increased rate of functional abnormalities and increased cytoplasmic retentions. Its activity is analyzed by creatinine kinase assay kits and is expressed in international units per 10 raised to 8 spermatozoa. Creatinine kinase test is useful to investigate patients with varicocele as high levels are frequently observed. It's a valuable guide for choosing either varicocele repair or assisted reproduction in these patients who have a varicocele. Nowadays, we do not do this test, but a long time back, this test was done. So I'm just mentioning it for a theoretical purpose. And that is the sperm penetration assay and the sperm zona binding test. They detect the defects in the sperm fertilizing capacity and can identify patients who will benefit from ICSI. However, since ICSI is routinely used during IVF for male factor infertility, this test is rarely done and is of low clinical value. Oligospermic and severely teratospermic men have a higher number of defective sperm zona pellucida interactions, which may account for their low fertility potential in both spontaneous as well as IVF pregnancies. There's significant problem in 35% of normal subfertile men. So what do sperm function tests try to basically achieve? They are basically meant to diagnose subtle changes in the function by a particular test or assay, and they help clinically to direct therapy as to which treatment is most appropriate and what are the chances of failure. So then, do sperm function tests improve the efficacy of diagnosis and treatment? And should it be done in all males of subfertility cases? But it is really debatable whether it should be done in all, but definitely they should be done in a few set of patients who have certain abnormalities. And it should not be a routine investigation as they are complex, expensive, not rigorously tested, do not always provide clinically useful information, and typically do not affect the treatment. There are certain tests which basically would help us in choosing the modality for treatment in these patients. So one can go for IUI if the concentration is more than 10 million, total motor current is more than 5 million, the 24-hour survival is more than 75%, TZI is less than 1.6, HOS more than 60, and DFI less than 15. One should go for IVF if the concentration is between 1 to 10 million, total motile count between 1 to 5 million, the 24-hour survival is less than 70%, TZI is between 1.6 to 1.84, HOS is between 50 to 60, and DFI is between 15 to 30, whereas ICSI is indicated if the concentration and total motile count is less than 1 million, the 24-hour survival is less than 70%, TZI is more than 1.84, HOS is less than 50%, DFI is more than 30%, and usually a TISA-ICSI is preferred if the DFI is more than 60%. So these three tests, what we do, are important in choosing the modality of treatment because the count and motility is already known to us. However, these other tests, though useful to indicate the chance of failure, but are not regularly performed prior to ART treatment because it cannot be performed with good repeatability and reliability and at a minimal cost. And the number to treat is about 100. So if you do a sperm function test in 100 patients, you will have 1 extra pregnancy. So we can say that sperm analysis will provide us direction for further evaluation and treatment. If it's normal, there's no therapy needed. If it is abnormal and non-treatable fertility disorder, one should go for adoption on donor insemination. If it is treatable and fertility disorder, a rational therapy could be given. Optimization of female reproduction function should be done, and the patient can be subjected to assisted reproductive technology. So I will end with the following take-home messages that conventional semen analysis does not provide precise information on the fertility potential of male subjects. Normal semen analysis may not reflect defects in the sperm function, and spontaneous pregnancies can still occur despite having abnormal semen parameters. There is no agreement on the definition of normal semen parameters, as they're being constantly revised in the light of new study results, and the use of sperm function tests is recommended to refine the diagnosis, mainly when in vitro fertilization is indicated and no clear cause of infertility has been found. WHO parameters are not sufficient to interpret the fertility status or chance of pregnancy in either natural or assisted conception. Male infertility workup goes far beyond a simple semen analysis, and a search for better predictor of fertility has brought the genomic integrity of the sperm into focus. The standardization of androgyny laboratories is essential. Semen analysis results cannot be used as a sole criteria for decision making. Multiple parameters may give better predictive value. Use of predefined treatment algorithms and data collection will be critical for improving understanding of fertility potential. Semen analysis is only a gross estimation of fertility, but is unfortunately the best test we have, and it can predict fertility in men with azoospermia, severe oligospermia, and globozoospermia. In other cases, semen analysis may have a limited role in evaluation of infertility because the female factors can influence fecundity in most couples. Coming to the conclusions on the sperm function test, they may be useful for identifying a male factor contributing to unexplained infertility or selecting therapy. There is a need for targeted sperm function testing, but to whom and which one is still unclear. New tools which are simple, cheap, reliable, repeatable, effective, combined with more robust assessment are urgently required. Despite the fact that ICSI can nowadays treat most patients with fertilization failure, the diagnosis of this failure in conventional IVF procedure is important, and this is where the role of a sperm function test is present. Thus, semen analysis alone is usually insufficient for diagnosis because it does not account for sperm dysfunction, such as immature chromatin, oxidative stress, as well as DNA damage. Therefore, further investigations of specific spermatozoal factors beyond semen analysis will contribute to the development of novel as more personalized approaches to test and treat the male factor. The endpoint of the infertile male evaluation is to find, if possible, a pathophysiological specific treatment to achieve a spontaneous pregnancy and reduce the need of ART, downgrade the level of ART, and increase the pregnancy rates when ART is unavoidable. Thank you for a patient hearing.
What a wonderful lecture. You have covered almost everything possible under the roof and male factor, infertility, and semen parameters, ma'am. So, how IUI can be done with immotile sperms 100% for which HOS test was done? This is a
IUI, it's not for IUI, basically, it's only for ART. So where we're going to select the sperm for an ICSI procedure, then only HOS may be useful in a totally immotile sperm sample. It cannot be used for IUI.
Ma'am, when there is no standardized lab, what are the parameters to be considered in a semen analysis?
So basically, the count, motility, and the morphology as the viability are very, very important that need to be tested.
And Namrata, I think ma'am answers your question simultaneously. Do we need to calculate all these indices?
Yeah, it is. And then,
Ma'am, when liquefaction alone is prolonged like more than 45 minutes, other parameters are normal. What to interpret, ma'am?
yeah, so I had given now what are the causes of increased viscosity. So basically, it could be related to infection as well as use of an abnormal, a container which is toxic to the sperms. And in those patients who have frequent ejaculation, these patients have So there are 2 or 3 things what we can do when there is a increased viscosity. One is that you can collect the semen sample directly into the culture media. Second is once the semen sample is collected, you can add the culture media and then examine the sample. And the third is that you can do rapid syringing of the sample, and this reduces the viscosity.
I think that's it, ma'am. Ortho question, I can't see any more question.
If there are any more, they can ask till time.
Yes. How many cycles of AID can we do, ma'am?
Yeah, so nowadays, according to the new ART law, artificial insemination with the donor sample or what is called as a therapeutic donor insemination should be done only in the presence of total azoospermia. As earlier, we used to do many a times even for oligospermia when the patient could not afford, but now we have to be careful when we are doing artificial insemination with the donor for these cycles. So here probably, again, as we say for IUI, that maximum we can do 4 to 6 samples. Same is the case with artificial insemination with the donor sperms also. And if they don't conceive, we have to, increase the scope of investigations of the female partner because she could be having other certain abnormalities and which we need to detect and then treat the patient accordingly.
Okay. Abnormal
Usually for all-
viscosity
Yeah, abnormal viscosity. Yeah,
equal to abnormal liquefaction time.
yes, yes.
That means no ICSI for all.
Yes, no
ICSI
ICSI
only
for
when
all.
its
ICSI should be
sperm
done only in
parameters are
indicated,
deficient.
yeah, only in indicated cases. It should not be done for all. But many a times there are embryologists who go to 3 or 4 patient places. So basically, they just do the ICSI and put it in the
Akanksha ko call karo.
media and go. Because if you have done IVF, the next day you have to denude the embryos and you have to check for fertilization. Whereas in ICSI, you have already denuded the oocytes and injected the sperm, so you need not check on the second day. And many a times these people who many embryologists go from one place to other, they put it
मेरे को बार बार
in
call
the
कर.
media. Abnormal liquefaction can impair spontaneous pregnancies, but it does not impair pregnancies with IUI or with the IVF or ICSI. ICSI basically does not increase the congenital anomalies, but it results in epigenetic changes, and therefore we should avoid as far as possible ICSI. But when it is unavoidable, you have to do ICSI. It does not increase the chances of congenital anomalies. There are several studies which have shown. When we categorize the patient into mild and severe, all the parameters have to be considered. It's not only the count. Everything, the motility, the morphology, as well as HOS, TZI index, we do everything. Basically, we cannot label with one report as azoospermia. We should, as I said in my talk also, if there's azoospermia, you need to spin the sample at that time. The pellet should be resuspended in 0.5 ml of culture media and that should be examined. If you see sperms in that, that means there's got cryptozoospermia or severe oligospermia. And if there are no sperms, it is azoospermia. This sample has to be repeated one more time before we label the patient as azoospermic. We cannot suggest donor insemination for recurrent implantation failure because we don't know it is because of which factor. Normal female doesn't mean that everything is normal. PGTA will tell us only about the aneuploidy. It's not going to tell us about the other abnormalities. And in PGTA, basically, one also needs to know that there could be mosaicism. So basically, if you do, initially, they used to do PGTA at the 8-cell stage. In a 8-cell stage, 4 of the cells will form the trophoectoderm or the placenta, and 4 of the cells will form the inner cell mass. So when we are when a blastocyst biopsy is done, many a times the trophoectoderm may be abnormal, but the inner cell mass may be normal, and vice versa. And many a times there are also mosaic where you have normal and abnormal cells in a PGTA. Affordability can influence the treatment, but if in males, especially if there is severe oligospermia, there's no other method of conception other than an ICSI procedure. If there is severe oligoacidoteratozoospermia. If it is just mild, you can do an IUI. Normally, what we advocate is at least the post-wash count has to be 5 million, but one can still do an IUI till about 2 million, though the results are much less.
I think that's it. There's no more question. Thank you so much, dear Dr. Madhuri and Dr. Sanjay, for such an insightful talk and interactive session. Till we meet on Monday again. Thank you, ma'am. Thank you, everyone.
So Monday, we have 2 cases, so we will start at 4 o'clock. So each case presentation will be for half an hour.
Okay. So we'll have to log in at 4.
Yeah.
Okay. Bye-bye. Bye.